Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, sir and miss. Today in here we want to present our presentation about case study couple practice that we just made before. And before we start our presentation, let me introduce myself and my partner. My name is Thufeil and my partner name is.
Mario Raphael Tampubolon.
Let's start with our presentation today. For the case right here, we make there is a 20 years old male with a history of poliomyelitis since age 2, presented with progressive right leg weakness, difficulty walking, and frequent falls. Examination showed muscle strength in 2.5, decreased tendon reflex and fires at the right knee, causing instability during stance and drop foot as well. A knee ankle foot orthosis or cable was prescribed to improve stability and mobility. And this is for the identification that we get from the patient. For the first one, there is a patient name. His name is Mr. T. And for the gender, he is a male. And the age right now, he is in 20 years old. And for the occupation, he is a college student. And for the height and weight, his height is 190 centimeters, and for the weight is 9 kilograms. And for the medical diagnosis, he has a post-polio syndrome and cause right lower limb weakness. And for the analysis that we got, the chief complaint, difficulty walking due to right leg muscle weakness since childhood. And for the medical history, he had diagnosis with poliomyelitis since age 2. And for the additional complaint, he had a mild muscle pain, fatigue when walking long distance. And this is for the physical examination of the muscle strength. From the quadriceps in the left side, he have 5.5, or we can say he's in normal pace. In hamstring left, we have 5, 2, and from the ankle dorsiflexor, in the left side, we have normal 2. But in the right side, from the quadricep, we just only get in 2.5. For the hamstring, he get 3.5. And for the ankle dorsiflexor, he have 2.5 muscle strength. And in here, in the gait assessment, we can see from the patient he had two dragging on the right leg, the right knee stability during stand phase. And the next one is there is a hip hiking trunk lean compensation, and there is a dependent on using a cane for long distance. And this is for the functional examination. For the first one, there is a difficulty climbing stairs. And the second one is there's a limitation in walking long distance without assistance. And the third one is there is a daily activity can still be performed with the aid of orthotics walking aids. And next one is there is a limited mobility when standing for long periods. And for the next presentation will be presented by Mario.
Thank you, Thufeil. Now I will explain about the orthotic goals. First one is to support knee and ankle stability, prevent excessive knee flexion to prevent falls, improve pain-free walking ability, reduce the need for walking aids, and increases patient independence. Next. For the prescription, first name design is molded K4 right lower rim. We choose the K4 because molded K4 has bigger area, so it will less pressure to the patient. Second is knee axis. We choose drop lock because patient has two grade 2 quadricep muscle and drop lock able to provide stability and prevent knee buckling. And third, ankle joint, we choose FO posterior leaf spring or PLS. FOPLS set in 5 degree dorsiflexion and dorsiflexion to prevent drop foot during walking to so patient foot more comfortable. Next, for design material and component, the material we use is polypropylene copolymer because it's durable and impact strength. Stainless steel sidebars and later tag and half cuffs. For the component knee joint, we lock during stance, unlock optional for sitting. For the ankle joint is PLS, FO for swing pace dorsiflexion assistance. Next. For manufacturing techniques is first detail measurements of the patient's feet and legs. Second is molding of the foot plate using thermoformable material. Third is assemble with knee and ankle joints. Fourth is finishing and adding padding for comfort. And the last is initial adjustment and trial in the clinic. Next. And for the follow-up, first, check-up after 1 week of use for adjustment. Second, routine check-ups every 1 month, 1 month for the first 3 months. Third, evaluation of gait function and comfort of HEFO use. Fourth, adjustment of manufacturing techniques if discomfort is found. And last, monitoring of motor development and muscle strength. Next. For patient education, we must teach the patient how to donning, doffing, and daily care of KFO. Second, recommendation for appropriate physical activity and follow-up therapy. For the third, information on the importance of supporting muscle exercise. Fourth, follow-up with a physiotherapist for walking therapy and muscle strengthening. And last, advice to contact the clinic immediately if skin irritation or discomfort occurs. Next. Thank you for listening to our presentation. We apologize if there are any mistake.